Okay, we're talking about cardiac medications out of your Abrams Pharmacology book, and it's me, your teacher, Lily Nolan. So we're going to start off in chapter 26 talking about antihypertensive medications because the purpose of these meds is to hopefully either slow the heart rate down, which will lower overall pressure inside the vessels, decrease the amount of fluid in the system to reduce pressure, or cause vasodilation to open and make more space in the vessels, so blood moving through has a lower pressure. So there's lots of different types of antihypertensive medications, and it just depends what mechanism of action they have. So let's talk about some general nursing considerations for antihypertensive medications. Whenever we give any type of medication, what we are hoping to do is to have a therapeutic effect for our patient and for it to be safe. And what we mean by safe is that it doesn't cause any other problems. It doesn't cause toxicity. It doesn't hurt the patient. It doesn't hurt any organs. It doesn't put them in harm's way, cause them to fall, etc. So how can we as nurses achieve that for our patients on antihypertensive meds? One of the things to be majorly aware of is that an antihypertensive medication can sometimes be too strong for a person and cause hypotension. It can swing them to the other side of the spectrum. So it's very important to know your patient's baseline vitals before you give this medication and have it be not only a recent pressure, within the last, hour or so, but to also sort of know their trend. Because somebody who normally runs in the 150s, they might feel hypotensive, dizzy, lightheaded, etc., maybe when they're in the 110s or something like that. Where if I just look at someone whose blood pressure is 110 over 65, I wouldn't think they would be hypotensive symptomatically. But if they normally are much higher than that, that would be a big drop for them. So knowing their baseline vitals, knowing what's normal for them, and being aware that sometimes when we start people on stuff, it can be too strong and we have to back off. So if a patient who is taking antihypertensive medications complains of a headache or feeling dizzy, we have to consider, is their blood pressure too low or is it too high right now? What's a good way to figure out? Take their blood pressure or make sure that they know how to take their own blood pressure, that they have a functioning cuff, that they know how to put the cuff on correctly. I think you all know at this point that is a hot button for me when people put a blood pressure cuff on wrong because there's no reason to. It tells you what to do. Otherwise, things we want to be aware of, allergic reaction. That could happen with any medication that we're giving to somebody for the first time. So if we suspect someone is having an allergic reaction, do not administer the med anymore. Call the doctor and let them know. We need to remind patients who are taking antihypertensive medications at home that they should not just all of a sudden stop taking their med. That can cause major problems with what we call rebound symptoms. So that means their blood pressure could then skyrocket. Their heart rate could become elevated. They are tachycardic. They could have chest pain. They could have arrhythmias. And they can even have an MI. They could have a myocardial infarction, especially beta blockers, if those are just stopped all of a sudden, for whatever reason. Sometimes people run out. Sometimes people just decide not to take it anymore. Sometimes with our older adults, when dementia starts to settle in, they just don't even realize they were supposed to be taking it. So that also kind of leads into my next point. We have to just be careful with the elderly, right? Whenever we're giving meds very, very young, very, very old, we have to be very careful. We want to start low with the dosages and go very slow increasing them and be aware of how sensitive their bodies can be. And if their kidneys aren't working super great or their liver isn't working super great, they are going to hold on to that med much more. Their body won't excrete it as quickly. And then compliance, the age-old tale. The meds can't be all that people are doing. It has to be a combination of medication and lifestyle changes. That's what's going to have the biggest bang for their buck, so to speak. So lifestyle modifications and then adding medications in on top of that. So the heart healthy diet, low salt, healthy fats, watching, high fat dairies, all those things that we've talked about together. Okay, so those are principles of administration of antihypertensive medications that you want to keep in mind for every single kind that we talk about. So as we mentioned, hypertension is when the force of blood pushing against the artery walls is consistently too high. So this little cascade of events here is hopefully what the body would do if it senses hypertension occurring. If it can't do these things naturally, that's where we give medications that cause or try and replicate the body's natural response. And so that's how the different types of antihypertensive medications are defined, sort of what part of the natural process is it trying to mimic. So if our body sensed we were becoming hypertensive, it would hopefully trigger the kidneys to excrete more fluid to then reduce the overall blood volume, which then decreases the venous return to the heart. So once in the heart, it would then reduce the cardiac output or stress on the heart, lowering the arterial blood pressure and vasodilation. Okay, so now we're going to talk about the different types of antihypertensive meds that exist. There's a bunch of them, all these different categories. Okay, so like I mentioned earlier, the cardiac meds are the most intense pharmacology grouping that we go over because there's so many and so many people are on them. They're so common. You've probably given a bunch of these in clinical last semester and you probably kind of knew what it was, but we're going to go into a little bit more detail. So you'll see down here I put diuretics and then first. So sometimes if people are very mildly hypertensive and they're maybe their lifestyle modifications have worked a little bit and the doctors just want to give something kind of light, they'll start with diuretics before they start working on more complicated aspects of that process. As we saw, the kidneys excreting more fluid was the first thing. So sometimes they'll actually give diuretics as the first antihypertensive medication. So just be aware of that. Sometimes the hypertension is too bad, it's too severe, that they can't do diuretics first. They have to use one of the more sort of complicated meds. But in an ideal situation, they would give a diuretic first. Okay, so we're going to talk about ACE inhibitors. So this stands for angiotensin converting enzyme inhibitors. So you can see why we abbreviate it. So what these medications do is they block an enzyme that causes vasoconstriction. So the whole overall thing it's trying to do is decrease vasoconstriction, and then you'll also see that it's trying to reduce volume with the use of decreasing water and sodium retention hormone aldosterone. And then it metabolizes a vasodilator. So bradykinin. So it hopefully increases the vasodilation. So these medications all end in pril. Captopril, lisinopril, enalapril, very common. So side effects, I'm not even going to mention hypotension because we've already discussed that every single antihypertensive med can cause that. Something unique to this is angioedema. Okay, so that's swelling around the eyes and the mouth and the face. And so that can be very serious. So if that's occurring, the doctor needs to be notified and they're going to have to come up with something else for that person. The other thing about prils, about the ACE inhibitors, is that they can cause a dry cough. They say 20%, I've seen as high as 30% of all patients on this have a dry cough. And it's nothing harmful. It's just really annoying. My dad was on lisinopril, and he just thought he had a cold for 3 months straight because of this cough. And he was actually in the doctor's office and did the cough, and the doctor was like, "That sounds like a very dry cough." And he said, "Yeah." And then the doctor asked a few more questions and was able to link it back to when he started on lisinopril. So he's no longer on that. But be aware that lab-wise, it can increase potassium, hyperkalemia. If a patient's also on digoxin or the medication lithium, it can increase the levels of those drugs. And those drugs are ones we need to watch very closely in terms of their therapeutic index and toxicity. Also, just kind of some FYIs, it can decrease the bioavailability of iron supplements. So if people are anemic and taking those, and those who are pregnant should not take this medication. Okay, next is angiotensin II receptor blockers. So angiotensin II is an enzyme that causes vasoconstriction. So this medication is going to block its ability to do that, to then hopefully provide vasodilation and lower the blood pressure. So what's nice about these is they're less likely to cause some of the problems that the prils did, like hyperkalemia and angioedema. All of these meds end in sartan, losartan, valsartan, olmesartan. Sometimes this class of medication is also referred to as an ARB, ARB. Sometimes all of the nicknames kind of make them harder to remember, but whatever works for you. When I see sartan, I think of tartan fabric. That's what this is right here. So some side effects with these medications are muscle cramps. And like I mentioned, the good thing is lower risk of angioedema, and pregnant people should not be taking this either. So I really like this picture from your book because it kind of shows the whole cascade that our body naturally does when hypertensive, and then it's showing where the medications work. So obviously the diuretics are there in the kidneys doing their thing. We just talked about the ARBs, so they're showing sort of a picture of the vessels there. And then the ACE inhibitors prevent sort of the conversion. So yeah, I just kind of liked it. If you're a visual learner, like we talked about in 104, this might kind of work for you a little bit. Okay, next class is calcium channel blockers. So these dilate the peripheral arteries and relax smooth muscle. And it's going to decrease overall vascular resistance. So if we have less resistance, we're going to have a reduced pressure. So how these work is they block calcium entry into smooth muscle. And one thing I've always remembered from my anatomy and physiology in college is that the professor said if you were to take a human heart and put it in a bowl of milk, it would pump just because of the calcium exchange across the membrane. So if you kind of think of it that way, if it's blocking that calcium, it's going to slow everything down, relax, vasodilate, and hopefully reduce pressure. This funny little kind of picture down here, this was my foray into AI artwork. And I said, I want a bottle of milk. And I said, I want it to be holding out its hand, stopping pine trees. And I tried a bunch of times, and this is all it gave me. So we're just going to go with it. And the reason is because calcium, right? Milk. And then all of these end in pine. So that's where I got the pine tree from. So anyway, amlodipine, nifedipine, all the pines. The only one I can think of in this class that doesn't follow this pattern is diltiazem, which is an extended release form. And we're also going to talk about this in a couple more slides when we talk about arrhythmias, because it's kind of used more for that than for blood pressure, but you still might see it. Verapamil is also one that doesn't play nice with the pattern, but no grapefruit juice, so keep that in mind. So some side effects, edema, especially patients who are in heart failure. These medications can make edema worse or cause edema in the first place. And then no grapefruit juice for nifedipine either. So just to be safe, I would just say, if you're on a calcium channel blocker, pick a different juice. You're not having a grapefruit. So then we have beta adrenergic blockers. So they're going to reduce the heart rate, reduce the force of contraction, reduce cardiac output, and reduce renin release from the kidney. And what's nice about these medications is by decreasing the heart rate, they're going to allow the heart to actually fill the atrium and the ventricle better, so that when they do pump, it's a more effective sort of fuller blood pump. So it's not going to build up unnecessary pressures, sort of pumping too much too hard, but it not being effective. So all of these medications end in lol: atenolol, labetalol, metoprolol. You've probably seen these a lot. So my question to you all is, what vital sign do we need, and where would we obtain it, and for how long, and when would we hold this med? So the answer to all these things is that we need to listen to the apical pulse for a full 60 seconds. We are then going to hold this medication if their heart rate is less than 60 beats per minute. So these are beta 1 blockers, and they affect the heart. There are also different types of medications that are called beta 2 blockers, and those affect the lungs. So beta 1 is the heart because you only got one heart. Beta 2s are the lungs because you got 2 lungs. Okay. So if this patient that you're about to give this to has liver problems, you'd want to hold and call the doctor because it can make those worse. Okay, so there's also alpha blockers. So they have the same action as beta blockers, but they also cause vasodilation in other parts of the body than just the heart. And so it's used actually a lot in BPH, which is benign prostate hypertrophy. So usually older gentlemen, their prostates get really large, and then it causes them to not be able to fully urinate. And so then they're frequently urinating up during the night and all those things. And a lot of these men also have blood pressure problems. So what they can do is actually kind of put them on one of these, doxazosin, terazosin, and it can kind of be a twofer. It does both, especially the doxazosin. Tamsulosin, that doesn't have a whole lot of cardiac power. So it's not as though a patient who is on tamsulosin, their blood pressure is going to drop dramatically or anything like that. So yeah, those are really the only times you see these used, is if someone also has BPH. So then we have medications that are called adjuvants. So these are medications that help the situation. So clonidine is a pretty potent antihypertensive medication. So it reduces norepinephrine. But one thing you want to keep in mind is that chronic high doses cause fluid retention. It can also cause edema. Clonidine has an interesting side effect of often making people very sleepy. So with that, and with blood pressure medications in general, we sometimes tell patients to take it at night, because then the initial kind of strongest effects will kick in when they are sleeping. Now, personally, sometimes that actually makes me worried, because if they're getting up in the middle of the night, it's dark, and if they're hypotensive, then they're going to fall. But that's just me being a worrywart. So then we mentioned diuretics. So one of the most common ones that they put people on at first is hydrochlorothiazide, which is abbreviated HCTZ. This is also in combination pills. So sometimes HCTZ is paired with some of the other blood pressure medications, and it just makes it easier for patients because then they can take one pill instead of having to take 2 separate pills. So just be aware, you might see, one of the antihypertensives / HCTZ, and just be aware it's a combination pill. And there's also furosemide, which we lovingly know as Lasix. That's a loop diuretic. And then spironolactone, that's one of our potassium-sparing diuretics. That also has some adrenal effects. So just kind of depends what the doctor thinks is best for the patient. But anytime we have somebody on diuretics, some things we want to keep in mind are really good daily weights, really good INOs, making sure we're not getting into a bad fluid balance where then they're too dry or too dehydrated. Okay, so dysrhythmias, we're going to keep it really short and sweet with this. So calcium channel blockers and beta blockers are often used for dysrhythmia therapy. So diltiazem and propranolol are the most common. There's also others called like amiodarone and things like that, but you're going to get into that more if you go into the RN program in 4th block. So I will leave that for them. So something to keep in mind is that we want to be mindful of that heart rate. So apical pulse for a full 60 seconds. If it's less than 60, we're going to hold the med and call the doc. Hypotension, we're also going to keep this very brief because, again, the real heavy hitters for hypotension you'll talk about in Block 4 in the RN program. So some drugs, just so you know the names of them, norepinephrine is a very strong vasoconstrictor because if someone's blood pressure is too low because of those reasons, they're septic or they're having, just sort of catastrophic cardiac failure and we need to tighten everything up. We will give something to vasoconstrict, but the problem is sometimes it constricts too much and can then cut off blood flow to other places. So if patients are on these meds for a really long time, like in an ICU or something like that, unfortunately, they can sometimes lose blood flow to like their fingers or toes or things like that. But I guess that's better than being dead, so I'll take it. And then there's epinephrine. So this is going to increase cardiac output. It also causes bronchodilation, which is why it's used also for allergic reactions and things like that. So it depends on the dose and the concentration for the reason that you're using it. One pill that is given PO for hypotension is midodrine. It's basically vasopressin in a pill form. Most patients that are taking this are dialysis patients, so they're in end-stage renal failure. So just keep that in mind. Okay, heart failure. So the sort of most commonly well-known med for heart failure is digoxin, which is a cardiac glycoside. So it has a positive inotropic effect. So that means it increases the force of the myocardial, the heart's contractions, and its ability to pump effectively. So it does decrease electrical impulses. So it's going to slow the heart down to allow for more blood to fill. And it's often used in different types of tachycardia or AFib for that exact reason, because we want to slow the heart down. So if it decreases electrical impulses and slows the heart, can you imagine when I would want to hold the med? Are we seeing a pattern here? Heart rate less than 60. Okay, I'm going to hold that med, call the doc. Other thing with digoxin we have to talk about is digoxin toxicity. So it has a very narrow therapeutic index, which means it can quickly go from being therapeutic and working well to then being toxic and dangerous for the patient. So some of the risk factors for digoxin toxicity are elderly and if someone has an electrolyte imbalance of potassium. So signs and symptoms we would want to be aware of as the nurse are if our patient is complaining of dizziness, any type of GI symptoms, nausea, vomiting, abdominal pain, things like that. And then vision changes. They may complain of blurry, halos, colors look off, things like that, or altered mental status. They're normally not confused, and now they are seemingly confused, things like that. This is the first thing you want to be aware of if they are on digoxin. So do not administer the dose. Contact the physician immediately if you are concerned, and then they can run the tests and all that. Okay, so like I mentioned, diuretics, sometimes these are also used in heart failure because the idea is to reduce the workload by decreasing the volume. So again, we have Lasix, HCTZ, still those daily weights, the INOs, keep all those in mind. And then, I should have made a new thing that said other meds, but statin medication. So these are not for heart failure. These are actually for increased cholesterol. So this is when lifestyle changes to reduce cholesterol, triglycerides, and phospholipids have failed. So this is for people who have an elevated level of blood lipids, and it's going to treat that, and it's also going to delay and reduce plaque formation from occurring. So not only does it treat the problem, but it helps to sort of prevent future problems of that plaque building up. So the technical name for these statin medications is hydroxymethylglutaryl coenzyme A reductase inhibitor. So you can sort of see why we call them statins instead, because that name is just way too long. So again, decrease the production of cholesterol, LDL, which is the bad cholesterol, and then triglycerides. So it takes about 2 weeks for it to start taking effect and do anything at all. So this is not sort of like an instant fix-it med, and it takes 4 to 6 weeks of consistent use for the full effect. So something we want to monitor for in our patients is any type of muscle pain, because this medication can cause rhabdomyolysis, which is basically where the body's eating itself. So all these meds end in statin. The most common one is atorvastatin. Just something to keep in mind. There's a few other types of sort of anti-lipid, anti-cholesterol medications, gemfibrozil, bile acid sequestrants, and things like that, which sort of work on different parts of the cascade, like the GI tract and the absorption, and then the synthesis with the liver and things like that. I just want you to know statins because they're the most common right now. So one thing to be aware of is that our cardiac patients might be on blood thinners. Might be in a preventative way, might be because they've had a cardiac event, might be because they've had cardiac surgery. So real quick and dirty here, if they are on warfarin, a lot of our older patients are on warfarin. It is the cheapest med. So warfarin, we need to be looking at their INR lab. The cardiologist will give us a specific parameter that they want the patient to be in. And so we need to be checking their INR, making sure it's not too high. And if it seems too low, we want to let the doctor know so they can increase the patient's dosage. And then there is heparin. We would want to look at the PT-PTT lab work to see how that's doing. Heparin is only given inpatient. You're not going to see a patient at home taking heparin. Lovenox is what's called a low molecular weight heparin. So this is an outpatient version of heparin. So there's a variety of different dosages people can be on because it's weight-based. And it depends if they're on a prevention dose, which is usually like 30 or 40 milligrams, or if they're on a treatment dose, which is when the weight base comes into play. And with Lovenox, it's all color-coded. So the different numbers are different colors. And sometimes people are on a BID, sometimes just once a day. Some patients are also prescribed aspirin. So ASA, that is the abbreviation for aspirin. So 81 milligrams would be a prevention dose that they take every day. 325 would probably be a treatment dose if they've had some type of procedure or cardiac events. And then medications that end in bands. So apixaban, that's Eliquis, rivaroxaban, that's Xarelto. These are the newer age blood thinners that they target a specific part of the clotting cascade. So they don't have a lot of the side effects that warfarin does, which is sort of a more generalized blood thinner. And there is no lab work for that. And then clopidogrel, that's Plavix. So what I really want you to know about these blood thinners is if there's a lab we should be looking at. And then things to keep in mind if you have a patient on a blood thinner. I know when I have a patient on a blood thinner, I'm concerned about something, and that something is bleeding. If they are bleeding too much, if every time I touch them they are bruising, if they're having frequent nosebleeds, if when they're brushing their teeth there's blood in the sink, God forbid that they fall or something like that happens, because what could have just been a simple bump in their head, if their labs are off, if their warfarin is way too strong and their INR is way too high, that simple bump in the head could be a hemorrhagic stroke. So things like that. If they're going to be going for a procedure, knowing when was the last time they took their blood thinner, When do they need to restart the blood thinner? I remember once when I was working med-surg ortho, I had a patient who was having quite a bit out from their drain, and I was supposed to give them Lovenox, and I asked the doctor, I said, do you want me to still give it? They are having, this much output. And he said, well, I can always give someone blood, but I can't take away a clot. And that completely changed my perspective. So if in doubt, always just call and ask and double check. All right. One last one. I just want to talk about the dangers of Sudafed. Okay. So patients who are on cardiac medications, who have hypertension, that are taking medication for that, they should not be walking into a pharmacy and just picking up Sudafed, pseudoephedrine behind the counter and taking it. It can cause severe vasoconstriction, increased heart rate, increased blood pressure, increased contractility, and it can lead to major cardiac complications. So if they are tempted to take something, they need to talk to their doctor first and make a plan with them, because we don't want something bad happening to them. All right, hope this has helped you guys. See you soon.